Right, welcome everyone. I think we are still letting people in, but in the interest of time, I'm going to get going. Welcome to this webinar, the Drugs Research Network for Scotland webinar on benzodiazepines and Z drugs. My name is Lisa Collin, and I'm co-convener of DRNS together with Anna Ross, who isn't here today, and then the rest of our team is Megan Calman and Marissa Bruce, who are also on this call. We have a great lineup of speakers today, so I won't keep you from hearing from them. We will listen to Jo, Gabby, Hannah, and Jenny, and then we'll have some time for questions at the end. Just to say as well, those who are just about joining us, please mute yourself. There'll be a lot of people in this call, so we just don't want to disturb anyone with feedback or anything like that. So make sure that you are on mute, and we will be recording this as well. So if you don't want to be captured sort of on the screen there, please turn off your camera. That is pretty much all I'm going to say at this point, and hand straight over to Jo.
Thanks, Lisa. Good morning, everyone. Thank you so much for coming to this webinar and to the DRNS for hosting us. So we're really delighted to present to you today. I'm Jo Kesten, a research fellow in the Bristol Medical School at the University of Bristol. And my time is funded by two National Institute for Health Research funded organisations, which are listed on this slide. And I am co-leading the qualitative aspects of this project with Jenny Scott. So I just wanted to start by acknowledging the wider team we're representing today, listed again on this slide. We've also been supported throughout this work by several voluntary sector organisations across our study areas, and without this support, this research would not have been possible. So we want to really extend our thanks to them and the participants of this research for sharing their stories. So the project overall aimed to understand the relationships between co-using benzodiazepines or Z drugs and opioid use, and how this co-use kind of interacts to increase the risk of drug-related deaths. We included Z drugs in this work as well as benzos because both work on the GABA A receptors and cause similar hypnotic and sedative effects, although they are chemically distinct. And we see similar trends between co-use of Z drugs and opioids and drug-related deaths, as we do for benzos. So what we plan to do in this presentation is give an overview of our findings, including an insight into the laboratory work that we've been doing. So the qualitative work we've completed really highlights gaps and areas of unmet need in drug treatment and other service provision for people who use benzodiazepines or Z drugs and opioids together. And in part, these gaps are the result of an emerging but still limited evidence base. At the end of our talk, we'd really value your reflections on what we've found and how to maximise the impact we have with this work and our next steps to really try and bring about change and ultimately come up with some longer term novel treatments or interventions which may help to prevent drug-related deaths associated with co-use. So just a little bit of background then. This project was developed in response to the growing public health concern or crisis of opioid-related deaths in the UK, particularly in Scotland. As I'm sure many of you know, or most of you know, one major factor behind these deaths is the use of multiple substances together, especially opioids and benzodiazepines. Opioids are involved in most drug-related deaths in the UK. In Scotland, they account for around 82% of all drug deaths, and of these, about 70% also involve a benzodiazepine. In England, 93% of drug deaths involve more than one substance, most commonly opioids and benzodiazepines. So a recent study using the Needle Exchange Surveillance Initiative, or NESI, found high levels of self-reported use of non-prescribed benzodiazepines, and this is also referred to as street benzos, among people who inject drugs in Scotland. This was most common among groups already at high risk of drug-related death, including injecting in public spaces. And recent self-reported benzodiazepine use was strongly linked to non-fatal overdose in the past year in this study. Despite this, there are very few tailored treatment options or harm reduction approaches for people dependent on both opioids and benzos, especially in England. Current guidance, so the Orange guidelines, advise against prescribing both drugs together. And if benzodiazepines are prescribed, it's advised that this is for a short time with a reducing or tapering dose, and rarely for more than 30 milligrams diazepam equivalent per day. Since we started this project 2.5 years ago, there have been some important developments. So in May 2024, the MAT standards on benzodiazepines were published to guide staff working with people who use both substances. And they stress the importance of really listening to and understanding each person's unique experience of benzodiazepine use to provide appropriate care. There's also been a review of studies on co-prescribing of benzodiazepines and opioids, and this review found that all-cause mortality increased by 75 to 90% when these two substances are co-prescribed. The evidence on overdose deaths was less clear, but did suggest a higher risk. Interestingly, the review suggests that co-prescribing may improve treatment retention, with people prescribed benzos alongside opioid agonist treatment staying in treatment longer than those who were not. However, because the studies included in this review couldn't fully account for other factors that might be impacting on the outcomes they looked at, a clinical trial is really needed. And this gap in the evidence base will be addressed by the InBoat trial led by Professor Katrina Matheson at the University of Stirling, which launched this month. So InBoat will test whether a tailored diazepam maintenance approach is more effective and cost effective than standard care, which, as I said, is a sort of tapering dose, a reducing dose, to see whether this intervention helps to reduce street benzodiazepine use among people receiving opioid agonist treatment in the UK. The intervention also includes psychosocial support tailored to the motivations for benzo use, including trauma and anxiety and harm reduction. And finally, in terms of the evidence base, the sort of backdrop to our work, new British Association for Psychopharmacology, or BAP, guidelines are expected early next year, summarising the latest evidence on co-prescribing. Okay, so before we talk about our qualitative findings, I'm going to share some insights from our ongoing pharmacology studies, which have been conducted by a team overseen by Professor Emeritus Graham Henderson and Dr. Chris Bailey, who are both in the audience, and also Dr. Anna Abdallah Paula Sheikh at the Universities of Bristol and Bath. So the laboratory work is looking at the effect of co-using benzos and opioids on respiration or breathing. There's different ways to measure changes in breathing, and what we're focusing on here is two things: the respiratory rate, which is the number of breaths taken per minute, and the second thing we're looking at is changes to how easy it is to breathe. So on this slide, we're presenting data from mouse experiments, comparing the effect of increasing doses of morphine with and without the same low dose of diazepam. And just to say, it's the convention to use morphine in these experiments because heroin is metabolized to become morphine. We've also run these experiments with bromazepam and found the same effect. Also, just to say that it's important to emphasize laboratory experiments are looking at effects in a very controlled way. So although they help us to understand what's happening to breathing, they're not attempting to mimic real life conditions, or sort of a human model, if you like. So if we start by looking at the graph on the left, the y-axis on the left-hand side shows the percentage decrease in the respiratory rate. So the higher the number here, the greater the decrease in the number of breaths per minute. And along the x-axis on the bottom shows the amount of morphine given. The orange line is when morphine on its own is given. And this shows that morphine decreases the rate of breathing in a dose-dependent manner. So the more morphine, the more breathing decreases. The blue line shows that when morphine is given with a fixed dose of diazepam, the decrease of the respiratory rate is greater at all doses of morphine tested. So just to highlight an example of this difference, when 10 milligrams per kilogram of morphine by itself is administered, this decreases the respiratory rate by approximately 30%, as shown in red, whereas when you add in 2 milligrams per kilogram of diazepam, the respiratory rate decreases by 50%. So this means when a benzo and an opioid are taken together, the slowing of breathing is greater. If we then move on to the graph on the right, we know that benzos relax muscles. And in this graph, the team investigated whether benzos make it harder for air to get into the lungs. And this was a question originally suggested by Professor Katrina Matheson. So a little bit of background, if you like. It's useful here to remember that it's harder to breathe in than out. So think of your lungs as like a balloon. You put a lot of effort into inflating a balloon, but when you let go or when you breathe out, the air flows out easily. So breathing in is active, whereas breathing out is passive. It just happens. So what we expect to see is a bigger effect of benzos on breathing in than out. And the question being tested here is, do benzos decrease airflow into and out of the upper airways? So just to orientate you to this graph, on the y-axis is something called the PIF-PEF ratio. PIF stands for peak inspiratory flow, which is the speed of air inhaled during a breath, and PEF is peak expiratory flow, which is a measure of how fast air is exhaled from the lungs. Looking at the ratio of these two measures of air coming in versus out means we can highlight differences in changes caused by benzos and opioids in the flow of air. And the x-axis here is the same as the previous graph, so it's the dose of morphine given. Okay, so the orange line shows that only at very high doses, as highlighted here, does morphine alone reduce the ratio of PIF to PEF. When given alongside a fixed low dose of diazepam, shown in the blue line, the effect of morphine happens at much lower doses, as shown in the difference highlighted in these red lines. So overall, when a benzo and an opioid are taken together, not only is the slowing of breathing enhanced, as shown on the left graph, the rate of airflow into the lungs is reduced. And these findings contribute to our understanding of the potential mechanisms underlying overdose associated with benzo-opioid co-use. Okay, so now we'll move on to the qualitative work, where we interviewed people who co-use, service providers who work with people who co-use, and we also ran some workshops with key interest holders. So firstly, Hannah, Gabby, and Hannah Poulter, who's also on the call, interviewed a diverse sample of 48 people who co-use from Glasgow, Teesside and Bristol. And the focus of these interviews was really to understand how and why people co-use and what people do in response to the risks of co-use. We chose these different geographical areas for their different levels of drug-related deaths and patterns of polydrug use. For instance, Teesside has a high rate of Z drug use. Where possible, our interviews were co-run by a university researcher and a trained peer researcher, which was extremely valuable, and we'd be happy to tell you more about that. And then we ran workshops with national experts to gather views on our findings and implications for harm reduction. From there, we decided to explore service providers' views on current clinical practice and harm reduction approaches. And so we interviewed 13 professionals across England and 11 across Scotland, and they came from a wide range of backgrounds and different job roles, including medical prescribers, frontline staff, and mental health service providers. And lastly, we held another workshop with the same interest holders to help refine our recommendations from across the entire project. So I'll now hand over to my brilliant colleague, Gabby, to say a little bit more about the sample and what we found from the interviews with people who co-use.
Right, thank you, Jo. Yes, just to say, so my name is Gabi. I'm a senior research associate at the University of Bristol, and I'm also the sort of Glasgow of Scotland-based researcher in this project. Now, I thought first off, I'm going to tell you a little bit more about the people we interviewed, so the service users. Oh, here, yes, sorry. So overall, we had 28 people in Glasgow. We interviewed 10 in Teesside and 10 in Bristol. And largely in terms of the demographics, our sample aligned with national statistics, for example, in terms of the gender split or the mean age. But of importance, we felt, was that almost like everybody in our sample reported to be a poly drug using, and this included alcohol. We had a really nice spread with people saying that they didn't drink any alcohol ever at all, to about 25% saying they used alcohol on a regular basis, up to, for example, 6 pints a day. Really heavy drinkers, they said. We also found that the majority of our sample reported to have experienced an overdose experience. And here we included people who also talked about lengthy periods of unconsciousness after co-use. And lastly, and perhaps quite staggeringly, the majority of people, I'm sorry, can this person just mute themselves? Sorry. The majority of people reported to have poor mental health. Now, this included people with official diagnosis. So, for example, post-traumatic stress disorder, psychosis, personality disorders, but also people talking about themselves thinking that they suffered from anxiety or depression, and often they connected this to adverse experiences in their childhood, such as sexual and physical abuse, neglect, but also experiences in adulthood, like homelessness, stigma from healthcare providers, as well as just a range of adverse things that were happening to them. We're now going to dive into the key themes we found from our interviews. So at the core of our findings, we found 6 co-use patterns. Now, they were all situated with a bit like within polydrug use, but we used their co-use sort of like dosages and quantities and frequencies to really mark them out. So in one cluster here, we've got people talking about like less control when they were co-using. For example, people reported to binge whenever they had money and they could get their hands on whatever drugs. And they also talked about heavily co-using throughout the entire day, huge amounts of drugs. On the other hand, we've got people talking about more control when they were co-using. So this would be for very specific situations or very specific tasks. So for example, people co-used specifically before they had to go into a social situation. So they were trying to deal with their anxiety, or they co-used in the evening, so before they went to bed, just so they were able to get some sleep. Now, these patterns were intrinsically linked to these patterns. So I'm sorry, I'm having problems with my clicking here, but just focus on the sort of orange bit, please. These are the motivations. So the motivations and the co-use patterns were intrinsically linked. So people co-used for 2 sort of meta motivations, and these were either functional or experiential in nature. So functional motivations, that's the upper line, and that is all about people basically co-using in order to get through the day, to make it out of bed, just to get their shopping done. So often it was to self-medicate and to drown out any poor mental health symptoms. But we also found that people talked about co-using for very specific emotions and feelings. So for example, people talked about wanting to get a wee buzz on. Often this was related to actually wanting to generate income. So there was a clear link between experiential and functional motivations. So the buzz and the generating income was especially pronounced when people talked about engaging in criminal activities. So it was about feeling energized, feeling strong, but also feeling invincible. So if you had to go and do some shoplifting, that's what you were after. On the other hand, we also found that people were seeking oblivion. And by this, they really meant just to stop existing, to stop thinking and feeling, and just to get away from everything. And often this was directly linked to people just trying to self-medicate them, because they just, on that particular sort of session or day, they just did not want to engage with any memories, any emotions, any trauma they had gone through in their life. So on top of the patterns and the motivations, we also asked people, what do you do or to keep yourself safe? What do you think are the risks for you when you're co-using? And we found overall that people were thinking about these risks and what they were doing. So on one hand, we had really strong narratives where people talked about having implemented their own sort of harm reduction and risk minimization strategies. And this, for example, could include people buying from only trusted sources, or we had people talking about they would be hiding their keys, their wallets, any surplus drugs, and texted themselves where these things were before they co-used. So at the end, when they came round again, they had the information where everything was, but they couldn't add on top of the co-use they were already doing. Now, this is in stark contrast to a different set of narratives where we found that people were absolutely hopeless and absolutely helpless, and they felt there was absolutely nothing anyone could do to keep themselves safe. And people talked about this hopelessness at various levels in the socioeconomic model. So we found it was for themselves as a person, but it was also evident that they had absolutely no trust in getting any help or any effective help at the sort of community and the service level. So this really then goes hand in hand with people talking about that what they really needed was what they really needed was support at the system level in terms of psychosocial interventions. In addition to, I'm sorry, can you please mute yourself? Sorry. Psychosocial interventions on top of getting benzodiazepine prescribing, so that they were not forced to use street drugs. So there was a very clear sort of tension and dilemma. So just to sum up, people talking about co-using in order to make it through the day, in order to function, and in order to drown out these mental health symptoms. But in the absence of these systems level supports, they felt they had absolutely no other choice but to use the street drugs. And at the same time, the vast majority talked about being absolutely terrified of overdosing. And I think this is perhaps best summarized in the following quote. Where this person in Glasgow told us, we need both. We don't just need the medicine, we need mental health support to work alongside each other to get the mental health input, but also to get the medications that's going to keep you stable, to give you a chance and rebuild your resilience, like getting over any traumas. But you say that to a healthcare professional and it just gets totally, no, you're not ready for it yet, or no, you're mad with it, or listen, you take too much drugs, or you're not taking drugs anymore, but you're taking alcohol, you're self-medicating, or it'll be no use giving you counseling. But then a lot of people need that counseling, because when you are coming off drugs, all your emotions are coming back to you. Years when you've taken drugs, you're numbing the pain. So once you are prescribed drugs, everything becomes clearer. And essentially, people talked about feeling like the trauma just slapped them in the face and slapped them down. So they needed this extra bit of help. So just to sum up, I was trying to convey here that people co-use primarily to function. We got this verified, if you want, from our workshops with people with lived experience. So the function on a day and co-using to enable yourself to do this was really that was it. And also to just escape the trauma and the adversities people were experiencing on a daily basis. Now, the motivation influenced how people co-used, but both the co-use patterns as well as the motivations were really volatile. So a person could start being motivated to co-use just to get through the day on a Tuesday morning. And by Tuesday lunchtime, it's a completely different set of motivations, because maybe they've like bumped into someone, really upsetting memory has come back, or they got into some money unexpectedly. So it was really dynamic, really volatile. And overall, our service users really, really stressed that there was such huge need for help at the system level, and it had to be appropriate and adequate to what they actually needed, to basically escape from this consumption roulette, which is a term Professor Macaulay termed, but it's all about not needing to co-use in the first place to get through the day required people these benzodiazepine prescriptions and the mental health interventions. So at this point, I'm going to stop chattering and I'm going to hand over to my colleague, Hannah Family.
Thanks so much, Gabby. So whilst I gain control, I can see why Gabby was confused now. I'm Hannah Family. I'm a research fellow in qualitative and behavioural science, and I work as part of the same two teams as Jo Kesten, so NIHR ArcWest and NIHR Health Protection Research Unit for Evidence and Behavioural Science. And I was responsible for some of the data collection in England, predominantly Bristol, and with people who are taking both these drugs. And also I collected the data for the English health professionals from England, and Gabby did the same in Scotland for us brilliantly. And I will say one personal thing, just to say sorry to Gabby, because I encouraged her to animate that beautiful rainbow diagram, and so she's probably cursing me inside her head for suggesting we did that. On to the findings. So I'm going to talk to you about the perceptions of staff and how they manage this tension really in the system that we have, that people are taking these drugs and actually we don't perhaps have the care pathways or the support in place to support people. So let's move the slide on. I might need some help because it's not moving. Aha. Our first quote from our service providers really sets the scene for this. This is from an advanced nurse practitioner who said, there's nothing across the whole of the region for people who are using benzodiazepines. And I'm saying, can we not stop prescribing stuff for cocaine and stuff for benzos? And the prescriber would be saying, you're the only one that wants to take a risk. And I'm saying, it's not about wanting to take a risk. It's like, we need to do something. It's so poor. Healthcare is so poor just now for people like that. And this was the tension that we saw across our data set. And we have this map of 4 interrelated themes that explain our healthcare professionals' findings in context. And these, as you look at it, these are actually kind of these conflicting thoughts and views and experiences that staff are holding, and actually they're not easy tensions to resolve. And this is what we saw, that all of these thoughts are interrelated and kind of in like a messy cycle. And sometimes this complexity led to inaction as well, because we're not quite sure how to resolve these thoughts. So at the top of it, all of our staff, it didn't matter what role they were in, they really understood the need that people had for a safe supply, that it wasn't safe for people to be relying on street benzodiazepines. And this acknowledgement that we have a safe supply or a safer supply in opioid substitution treatment, but that we don't for benzodiazepines. On the flip side of this, the safe supply would be a prescribed benzo, for example, alongside an opioid. But staff really felt that they didn't want to cause harm. They weren't sure how much to prescribe. They weren't sure whether it was the right thing to prescribe, because they didn't want to contribute to short-term harm, such as a fatal overdose, or longer-term harm, so providing maintenance benzos and perhaps that having impact on people's cognition later in life. And so there was this real tension of, I really want to help someone find a safe way of managing their dependence, but I don't know. I don't want to cause you harm. I don't want to be the one who's contributing to a fatal overdose. And then there was a difference that we saw between prescribers and our harm reduction experts and our mental health specialists who didn't have prescribing responsibilities. So for our prescribers, there's this real fear that they could contribute to someone's overdose, whereas the harm reduction and mental health specialists were just so worried about the risk of people relying on street street sources, and that there might be a contaminant which was far more potent than a person realised, and they could inadvertently have a fatal overdose. So there was a bit of a tension between different groups of health professionals, but they all really just wanted to reduce the risk. And part of that as well was that for the prescribers, there was a fear that there was perhaps some potential for manipulation in this. If we started co-prescribing benzos, would there be more diversion? Would people overemphasize their need or their dependence on benzodiazepine in order to get benzos which could perhaps work alongside that opioids and produce a euphoric, pleasurable experience? So, and they didn't want to be prescribing for that side of things. They're very happy to support people with dependence, but not to support kind of seeking euphoria, especially when the risks were potentially so high. On the other side of things, there was also a sense that it was completely futile to be prescribing benzos short-term or long-term, because actually they acknowledged that it was not enough, and they really saw this mental health need and this gap in mental health support for people, so that they knew that if they prescribed, even if it was if they prescribed a detoxing dose, for example, or detoxing regime, that people were going to struggle with that because there wasn't the mental health, there wasn't the appropriate mental health support that they could help people to access to manage those symptoms that they knew would emerge as people stopped taking benzos. So this brings us right back, really, if I manage to get the animations to work. It's gone now. There we go, here it is. It's gone really back to the start of where we were with this project, which was that there was this gap, and that there's this real need for guidance and also evidence, that we don't have the evidence to show health professionals that if you prescribe this short or longer term benzo maintenance dose alongside opioids, it's not going to cause people longer term cognitive harms and things like that. We don't have that evidence base in place. We can't say yet what is the safest approach. But this gap means that there is nothing in place for people who are dependent on both these drugs. So we need this guidance, and we need the evidence to support the development of this guidance in order for us to provide this support. So that's kind of summarised what I've just said. And so this lack of that we don't have this guidance, and in turn the evidence-based care, and we don't, in ways we don't quite know yet how to support people who are codependent on street drugs. We have the INVOKE trial, which we mentioned at the start, which Professor Matheson is running, and so we can look forward to the results of those. There's also, we've got some translation of limited evidence from prescription benzodiazepine monodependence. And when we talked to health professionals, they were really confident in managing this, but really felt that this did not relate to the management or all the things that they could do to support people who were dependent on both benzodiazepines and opioids in the wider context of polysubstance use as well. And I think what we really need to emphasize is that the awareness that benzos and opioids may play a big part, but also wider polysubstance use, and it's hard to prescribe in the context of all that messiness, that there was just so much complexity. We also heard from drugs workers and harm reduction specialists who really wanted more training on polysubstance use and also the pharmacology of drugs. So we have a wide range of benzodiazepines that people can access on the street, for example. They have different onsets of action. And it's not that you can ever tell someone if they're taking street benzos what might be in them, but you could kind of educate and say there are so many different rates at which this drug can kick in. And this is really important because what we heard from people when they were taking benzos and opioids was, particularly if they were kind of using the less controlled patterns, that they'd throw a handful back. A few minutes later, if nothing had happened, they'd be throwing down more. And it's having that context that we can help explain to people that actually it might just be a different type of benzo. It might take longer to kick in. And also explaining the different durations of action as well, and so that some benzos might last in the body longer and so therefore may have longer overlapping effects with their opioids as well. Things like that would have been our harm reduction specialists really felt would be really useful to know more about. What I can say is that when we look, because we had this brilliant opportunity to talk to colleagues in Scotland where they do have the benzo-informed MAT standards, and colleagues in England where we don't have any kind of national guidance in this matter, that you could see the difference that guidance made. So In England, because we didn't have a national prescribing policy or guidance at national level, we saw quite a big variation in what people were doing. Organisations taking different approaches. Some organisations saying we don't prescribe any benzos at all. We have a no benzo prescribing policy, through to places where there would be some ability to prescribe benzos on low dose maintenance, or prescribe a fixed benzo detox alongside opioids. So we had this inconsistent prescribing. It really depended where in England you lived, that in terms of what you would be able to access. Mostly people struggled to get benzo maintenance. It was very rare that we heard that people could get benzo maintenance. So it was detox, and it was 12-week detoxes. So they weren't gradual detoxes, which are more helpful for benzo detox programs. And importantly, and I think this is really crucial to highlight, is that not only did this lack of guidance around benzo prescribing in the context of co-use impact the kind of co-prescribing, also impacted on OST provision as well. So even if they weren't prescribing benzos, if they knew someone was taking benzos, then they were also much more cautious in what they would prescribe as an OST dose for people. So OST was not being optimized either. And so it's those spillover effects of this lack of evidence that's really important as well. We also heard a lot, and this was both from people who we spoke to who were taking both benzos and opioids, and also staff that self-detox with little to no support, typically kind of referencing the Ashton manual was the way that people were supported with their benzo use. And so there just wasn't much in place in those settings or those scenarios to help people. By contrast, in Scotland, staff felt more confident, more reassured in their ability to prescribe, because they had been given a framework for considering both the risk for the person and having that discussion with the person about we can co-prescribe. This is not necessarily a safe approach. This is a safer approach for you, and discussing the risks and benefits of that. But also for considering professional risks. And because there was guidance and a framework for doing this, the professional risk felt less immediate. Whereas in England, the prescribers really felt very worried about the professional risk for them. The priority was the patient, but they also really strongly acknowledged that there was a risk for them as well. OST optimization was seen as important, and that was possible because we had the framework in Scotland that supported people to have those discussions around benzo opioid co-prescribing. However, there were challenges for those not on OST and in rural areas or small teams. So, I'm going to try again. I'm sorry, I'm just trying to change slides. I'm going to hand over now. Thank you so much for having us, to my colleague Jenny, who's going to talk you through our final part of the research.
Thank you very much, Hannah. Good morning, everybody. I hope you're still hanging in there. My name is Jenny Scott, and I work in the Centre for Academic Primary Care at Bristol Medical School. I'm a pharmacist, and I also work clinically as a non-medical prescriber for Turning Point, who are one of the third sector treatment providers in England. My job in this talk is really just to pull together everything you've heard and talk you through our conclusions, and importantly take you through the recommendations that we have come to with our advisory workshops and our research findings, and then hopefully we can hear your thoughts, and very much want to be able to draw on everyone's views on this call as well. So just to take you through, first of all, our conclusions. And we put this quote in at this point because this really did capture the situation, particularly from the perspective of prescribers. So this psychiatrist said to us, the very top priority is recognising that co-use of benzodiazepines and opioids is an issue. It's killing people. It's making people live lives that are really not the kind of lives that they want to live. It's a big issue, and currently there's not a lot getting done for these people. So that really did capture both sides of what we heard. So in conclusion, so what have we told you? If you've been asleep the last little while, here's a summary. People felt left to manage their benzo use on their own. particularly in England. They really felt that they were at sea, and that whereas with their opioid use there was support, they felt their benzo use was not adequately supported, and they were left to try and manage it on their own. Obviously, this is our findings from our group. We're not necessarily generalising about the whole population, but in the people that took part in our research, this is what we heard. We also heard that the lack of guidance and the lack of evidence that to underpin guidance led to variability in what was going on around prescribing, particularly in England. And there was a sense that because benzo use and co-use is not really addressed, that this was because it wasn't seen as worth it, that people felt stigmatized, they felt that their needs were being ignored, and really sort of, as I said, felt they were out at sea. Obviously, we've talked about in Scotland that within the MAT standards, there's guidance on benzos. And within that, there is talk about partnership working, so about shared decision making, which is conceptualized around this term zone of acceptable risk, where the prescriber and the individual reach a compromise on the risk that both sides take in order to try and manage safety or safer prescribing. And we're really interested to know how that plays out in a practical setting, and how that works, and whether that actually does support both prescribers and individuals who require prescribing. And finally, mental health support for people who co-use is really urgently needed. Our sample made that very clear. And we also had a suggestion from the prescribers that we spoke to, that if there was more mental health support that people could access, they may feel more confident to prescribe benzodiazepines, because there would be a pillar of mental health support provided to people alongside the prescription. Okay. So I'm just going to talk you through the recommendations that we have, and I'll show you where you can read more about our work as well. And I also want to acknowledge that there are obvious tensions around some of these recommendations that need further work through, further consideration and wider discussion and debate. So we just want to be really upfront and put those out there. So our first recommendation is the need for prescribing and normalised prescribing to help people live and help people function, and for that to be flexible and tailored to the individual. That was really clear from the people that we spoke to who are impacted by co-use, and who Gabby discussed in her part of the talk. But we really recognise that that's a challenge, and it's a challenge for prescribers, and the potential risk of harm, whether that's short-term or long-term, and the uncertainty that prescribers have, and the unwillingness around risk-taking because of a kind of lack of evidence, a lack of framework, lack of guidelines, as Hannah said, particularly in England. And we acknowledge that there, of course, is ongoing work to try and address some of the evidence base that is lacking. Our second recommendation is the need for specialist mental health support, and adapted to the individuals, because people may not be able to, even if they were provided with mental health support, may not be able to engage at a pace or in a way that they could if they were not using benzos. We recognise that in many settings, people's drug use is a barrier to accessing services, and that services do have limited resources, competing priorities, and very often are struggling to meet needs of the wider populations. But nevertheless, it was very emphasised and key on both sides from individuals who co-use and from professionals that this gap is huge. Next, a need for treating people holistically and providing psychosocial support to improve people's everyday lives. Some people had access to some support, particularly if they were in receipt of opioid substitution therapy, but there was a definite need from the people we spoke to for help to improve their health, their well-being and their resilience. And as I said, similar to the mental health, some of these interventions need to be maybe in smaller steps or more intense. And that's led to our team to consider whether there's a specific role here for peer navigators and people with lived experience to sort of help people to engage with and to stay engaged with this sort of support. Next recommendation is around harm reduction information. I think Hannah made it really clear that people who provide interventions, provide services, staff had gaps in knowledge around benzodiazepines, around taking substances orally as opposed to injecting them or smoking them, and didn't really always understand differences between the pharmacology of different benzodiazepines or the effects of different formulations. And of course, we have very little evidence on illicitly manufactured formulations as well, which makes it more difficult. But there's a definite gap in training and information for professionals. And this is mirrored by a lack of information on the same for people who co-use drugs themselves. And again, a gap in the harm reduction literature around this. So it's something we feel is important to address. Okay, so just to wind up, what would we like to do next? And this is a bit of an appeal for your involvement as well. We're obviously keen to share what we've found and what we've learned with as many people as possible and to hear feedback on this. We would like as our next step to develop an intervention that addresses the recommendations that we have. And we also understand that there are lots of different people working in this space at the moment, and we're really keen to connect with people from practice who are developing and working in innovative ways with this client group, and people from other academic settings, and in particular mental health providers as well, because this is an area we feel really needs to be looked at around engaging them as well and in developing interventions. So you can download our booklet with our findings and recommendations from this code. We've also got academic papers published and a lay summary, so there's codes here that you can use to access those. And just to finish, I want to acknowledge everybody who has supported us in this work and who's really behind these findings. Oh, moved itself on of its own accord there. So yes, so our participants and our funders, who you can see here, and our artists who worked with us and worked with people with living and lived experience to create the graphics that you've seen throughout our presentation. So thank you very much for your attention. We would now really welcome the opportunity to move on to hear your thoughts, answer questions, have some discussion. And we have got our, if they are, you can get in touch. Oh, and it's gone. You can get in touch with us by email. I think, yes, so there you are. Or you can find us. We're not hard to find. We're hidden. Not hidden. We're all over the place on the university website. So thank you very much. The presentation, we're not going to share the slides, but the recording will be made available. So thank you. And the reason we're not sharing the slides is the pharmacology work is not yet published. But and we're very happy if you wanted, actually. I think we could probably email out all the QR links if you wish. So yeah, thank you very much. Now back to you, Lisa, I think.
Well, thanks so much, Jenny. Thanks, Hannah, Gabby and Jo. all of you for presenting this, and it's so nice to see all of these pieces of work coming together in one presentation. I think I've seen bits of it at different conferences and things, and it's just really nice to see it all and kind of in well, squeezed into an hour. I would say there's so much work in there. And I would just like to say as well, like the illustrations you've got for the work are phenomenal. I always love them. So I'm just going to start with a question in the chat, and then I'll try my best to kind of get people, if people want to unmute themselves and ask a question, just raise your hand first and I'll try, because there's over 300 people in this call. So I just want to start with a question from Paul. And he was asking if the panel had some thoughts on Scotland's years of high overdose rates to forced benzo deprescribing, driving people towards illicit nitazene-laced use. If you got any comments on that to start us off.
This is the bit we didn't rehearse. Who was going to answer the questions? So my understanding is the question is, it has not prescribing benzos led to increased overdoses. Obviously, that's not directly within scope of what we've presented, but clearly, you know, when people are seeking substances that are not regulated and not controlled manufacture, there is going to be increased risk. And we know that the majority of drug-related deaths in the UK, including in Scotland, are polysubstance deaths. So, and we also know that some of those benzos implicated in those deaths in Scotland are not pharmaceuticals. So the atizolam, bromazzolam, things we've seen in past years. So I think my take would be on it. Yes, we know that unregulated market is a contributing factor to drug-related deaths. And so then the extension is that if we regulate, if people receive a regulated quality controlled supply, we potentially are reducing the harm and the risk. Anyone else?
Yeah, I was going to say, does anyone else want to come in on that one as well?
I would just add that I agree it's important to consider how changes to policy impacts on illicit substance use. So if we see decreasing prescribing, do we see increasing illicit substance use? So yeah, I agree it's important to consider, and there are risks related to prescribing and risks related to not prescribing. So I think it's a really complex issue, but I agree that policy changes will have an impact. Thanks.
Brilliant. Okay, so I'm going to move on to someone who's raised their hand, and I'm going to play my I am Swedish card. Sinead, is that the right way to pronounce it? Do you want to unmute yourself?
Yeah, you got the name perfect, don't worry. I thank you for the presentation. It was fantastic, but I suppose I have a few questions in relation to the kind of non-fatal overdoses and drug-related deaths in Scotland for those who are currently prescribed benzo prescriptions, because I feel there's a large proportion who are. And are we capturing data on that? And like, I suppose comparing the risks for both parties.
That's a really good question, Sinead, and I don't know personally. Being based in England, I haven't seen any data on Scottish deaths that separates out whether the substances are prescribed or not. We're very fortunate in England. We've got data set that Caroline Copeland looks after at King's College, where sometimes she's able to deduce that. And in fact, we're looking at that around methadone deaths at the moment. But I don't know. There might be somebody else on the call. I think Andy McCauley was on the call, not to put him on the spot, but there might be somebody else on the call that does know. Oh, Andy says the data is imminent. The paper is in preparation. So there you are, Sinead. Watch this space, or watch Professor McCauley's space. Thank you.
That's
Andy.
fantastic. Thank you. And just I'm mindful that, you know, in Scotland some years ago we did give significant quantities of diazepam prescriptions along with OSD, and we have a significant drug-related deaths population, you know, in comparison to England, Northern Ireland and Wales. So, you know, whether or not there is significant risk with prescribing. But again, that's just my 2 cents. Thank you.
It's a really good point. Thank you.
Is there anyone else who'd like to ask a question? I'm trying to keep an eye on the chat. So there's someone who's asked if people are using high numbers of street benzos to self-medicate their mental health, if there then is a clear pathway or link between prescribed diazepam and preparatory work in regard to accessing mental health support and psychosocial support. Are there pathways like this getting utilised rather than just prescribing diazepam and not utilising this as an opportunity to provide and access mental health pathways? If anyone had thoughts on that.
Oh, I wonder if Gabby and I can chip in here. So I think there's a lot of our data really shows that people were being referred, and this came from both people, the service users, for want of a better term, and also staff, that people were being referred for mental health support but being declined for that support. So for a whole range of reasons, I think Gabby showed a beautiful quote that kind of captured some of that at the start of her section of this talk, which was that, you know, you're not ready, you're taking your prescribed benzos. These were all major barriers to people accessing. And we heard a lot about people's short-term memory having an impact on people's ability to engage in mental health support. However, actually in Scotland, and Gabby can tell you more about this, we actually heard from colleagues who'd found strategies to support people who were taking benzos and opioids and other drugs, but particularly the benzos because of the short-term memory issues, to support them through mental health support. But it was just used as a kind of blanket reason to decline people for treatment. And I think what that speaks of is the pressures that our mental health services are under, because they don't have parity of funding, and they just the boundaries come up because they just have to manage, you know, they have to find some way of managing. Gabby, do you have any examples you can give in terms of the kind of good practice we heard about?
I'll be totally honest with you, my mind's gone totally blank and I've got no examples. But instead, I think what we've got from our service user interviews is on one hand is a clear understanding that people have experienced horrendous things throughout their life. There was not one person talking about how amazing life is and it's just so much fun, and you just go use because you've got nothing else to do. So much adversity, which becomes just part of your life. It's and an understanding that this fuels your co-use or your poly use, and hesitation to tell your healthcare providers or the person who might be prescribing why the things are in your life the way they are. I don't think we went into any depth, but the level of stigma people were experiencing when they were trying to get prescribed drugs, or when they were trying to get any help, was really quite high. Bearing in mind this is a self-report perspective, but it is people's experience of their life. So I think us personally, we thought, I think in Scotland, the third sector, so for example, the Scottish Drugs Forum, in England, I think it's the Bristol Drugs Project we worked with most closely. People with lived experience are like peer navigators, as Jenny was saying, is the way forward when it comes to mental health as well, like in terms of opening up and actually saying this is what I'm going through, this is what I'm feeling, this is what's happening inside of me, is a lot easier to talk to someone where you go like, you know what I'm going through, rather than someone with 2 doctor titles and sitting in front of you and just trying to get you through a 10-minute sort of consultation. Yeah, so I'm gonna chat. Stop talking here.
Thanks, Gabby. So I see that there are more questions popping up, but we're coming up to 12 o'clock. So I'm going to actually be a very good or a bad chair and say we're going to cut it there. But there's some really interesting kind of back and forth in the chat as well about people discussing various bits. So everyone can kind of have a look there. And if I'm sure, as you said, you're not difficult to find. So people who had additional questions can reach out to you. But thank you so much for presenting today. And I think we can kind of help. People have been asking about any links to the QR codes and things. I think we kind of try and connect with people after to make sure everyone's got all the links. But thanks, Jo, Hannah, Jenny and Gabby for today. It was really, really good, and glad that so many could join us online. So have a nice rest of your Friday and a good weekend when it comes.
Thank you. Thanks for hosting us.
Thank you, Lisa.
Bye.
Thank you.
Thank you.
Right, welcome everyone. I think we are still letting people in, but in the interest of time, I'm going to get going. Welcome to this webinar, the Drugs Research Network for Scotland webinar on benzodiazepines and Z drugs. My name is Lisa Flynn, and I'm co-convener of DRNS together with Anna Ross, who isn't here today, and then the rest of our team is Megan Callan and Marissa Bruce, who are also on this call. We have a great lineup of speakers today, so I won't keep you from hearing from them. We will listen to Jo, Gabby, Hannah and Jenny, and then we'll have some time for questions at the end. Just to say as well, those who are just about joining us, please mute yourself. There'll be a lot of people in this call, so we just don't want to disturb anyone with feedback or anything like that. So make sure that you are on mute, and we will be recording this as well. So if you don't want to be captured sort of on the screen there, please turn off your camera. That is pretty much all I'm going to say at this point, and hand straight over to Jo.
Thanks, Lisa, and good morning, everyone. Thank you so much for coming to this webinar and to the DRNS for hosting